Let's do a summary of the screen test we do during pregnancy. So, in the initial visit, which most of the time is going to be during the first trimester, the initial visit, we do complete blood cell count, we do RH and blood type of the mother, we evaluate for infectious diseases, for example, the PPD test, and if this is positive, then we will go to order a chest X-ray. HIV test, the screen test is with ELISA. Non-specific test for Treponema pallidum, which is the VDRL and the RPR. If this is positive, then we should evaluate this with FTSA, the specific test, and MHA. If HIV is positive, then the confirmatory test is with Western blot. Also, we take we want to order tests for chlamydia, Neisseria, hepatitis B surface antigen. We want to evaluate the status for rubella infection, so we will draw antibodies for rubella. Sometimes we can also test for hepatitis C, depending on the population, but practically is complete blood cell count, the RH and blood type, and the screen for diseases, so tuberculosis, HIV, hepatitis B, chlamydia, Neisseria, Treponema, and rubella. Then at 9 to 14 weeks gestation, we can do the nuchal translucency test, for aneuploidy, but most of the time the nuclear translucency test is combined with the combined test is the nuchal translucency plus beta HCG plus pregnancy associated plasma protein A. All this is done between 10 to 14 weeks gestation. At 10 weeks gestation, we can also do the cell-free DNA test. Then from 15 to 20 week gestation, we order maternal serum alpha fetoprotein, but most of the time this is done as the quadruple test, which is maternal serum alpha fetoprotein plus beta HCG plus estriol plus inhibin A. Then this is 15, 20, 23 weeks gestation. Then at 24 to 28 weeks gestation, we do the universal screen test for diabetes mellitus. In cases of a patient with high risk of diabetes, the screen test should be during the first trimester. That is only in case of a high risk patient. It's ready to screen test. Then at 28 to 30 weeks gestation, we order the atypical antibody test, which this is we want to evaluate if the patient, this is only done if the patient is Rh negative. If the patient is Rh negative and she had, for example, a previous baby, we want to know if this patient is sensitized with the positive Rh antigen of the baby. So we just know the patient is an Rh negative, and if she is negative, then we will apply the ROGAM vaccine, which is not a vaccine, but that is how it's called, the ROGAM vaccine. But before administer ROGAM to the Rh negative woman, we first want to see if she is already sensitized. If she is already sensitized, there is no need to administer the ROGAM. So if she is sensitized, that we are going to evaluate it with the indirect COM test, which is the atypical antibody test. If for some reason we know the patient is Rh negative and the baby of this patient is also, the previous baby of this patient is Rh negative, so the patient is not going to be sensitized because of that. And we want to know if in the actual pregnancy this baby is positive. So in summary, we want to know if the patient is sensitized prior to administer the ROGAM. So to evaluate that, we do indirect COMS test or atypical antibody test before administer ROGAM. If the patient, if she is Rh negative and she has not been sensitized, so if there is no atypical antibody test, then we will administer the ROGAM. And between 35 to 37 week gestation, we take culture for group B streptococci, and this is a good time to repeat complete blood cell count to reevaluate for anemia, which could be apparent now that the pregnancy is advanced and the baby is consuming more iron than at the beginning. And then at 34 to 40 week gestation, if this is a patient with high risk of sexual transmitted disease, we reevaluate for sexual transmitted disease. We could also test for chlamydia and Neisseria. If against a patient with high risk, we will test again for HIV, for example. Syphilis also. If the patient is positive for group B streptococci, we are not going to treat that because it's not an infection, actually, it's more like a colonization. So the only thing we will do in this case is to give intrapartum penicillin. So screening test during pregnancy is at initial visit, which is during the first trimester. Complete blood cell count, and also biochemical panel, metabolic panel, which is electrolytes, blood glucose. We want to evaluate and complete how is the patient. So initial visit during first trimester, complete blood cell count, metabolic panel, RH, blood type, urine analysis, and urine culture. PPD test, ELISA, non-specific treponema test, chlamydia, Neisseria test, hepatitis B surface antigen, rubella antibodies. At 10 to 14 weeks gestation, 10 to 14 weeks gestation, we evaluate for nuchal translucency. The combined test is nuchal translucency plus beta-HCG plus protein-associated plasma protein A. At 10 weeks gestation, we can do cell-free DNA test for aneuploidy. At 15 to 23 weeks gestation, we do quadruple screen test, which is maternal serum alpha-fetoprotein, beta-HCG, estrione, and inhibin A. 24 to 28 week gestation is the universal screen for diabetes mellitus. 28 to 30 week gestation is screen for sensitization for an Rh negative patient. If the patient has no antibodies, then we administer Rogam. So this is the time to test and administer Rogam. Then 35 to 37 week gestation, culture for group B streptococci, and we can repeat at this moment complete blood cell count to evaluate for anemia. And 30 to 40 weeks, we repeat screen for sexual transmitted disease in high risk patients, or if the patient was positive on a previous test and she got treated.